Caesarean section is a surgical procedure in which a baby or babies are delivered through an incision made in the mother's lower abdomen and uterus. A caesarean section may be planned or elective, that is, planned in advance, usually performed at or around 39 weeks of gestation, or an emergency or non-elective. Most commonly performed when you are in labour, often because labour is not progressing well or the baby is showing signs of distress. About 30 in every 100 pregnant women in Australia will have a caesarean section for the birth of their baby. The majority are planned caesarean sections. The common reasons for having a caesarean section are a caesarean section in a previous pregnancy, the placenta is low in the uterus and covering the cervix, placenta previa, the baby is not coming head first, for example in a breech presentation, buttocks or feet first, a multiple pregnancy and conditions are not favourable for vaginal birth, or concerns about the well-being of the mother or baby, for example if the mother develops high blood pressure, preeclampsia, or the baby is not growing at the expected rate, intrauterine growth restriction. There are many other reasons that you and your doctor may decide that a caesarean section is preferable for the delivery of your baby. There are many other reasons that you and your obstetrician may decide that a caesarean section is preferable for the delivery of your baby. Your obstetrician will explain the particular reasons for your caesarean section. You should ask any questions you have at that time. You will be provided with a list of things to bring into the hospital for you and your baby. Usually, you may bring a camera into the operating room to take photos of your baby as soon as he or she is born. However, most hospitals do not permit the use of a video camera in the operating room or the recovery room. In most cases, you will be admitted to hospital on the day of your surgery, accompanied by your partner or support person. You will be notified of the time from which you have to fast, that is, not eat or drink, usually for 6 to 12 hours prior to surgery. You will also meet your anaesthetist prior to the surgery. You may be asked to drink an antacid medication just prior to surgery to reduce the amount of acid in your stomach at the time of your operation. You will be given an anaesthetic so that you do not feel the surgery. The anaesthetist will be with you at all times. There are two types of anaesthesia: regional anaesthesia and general anaesthesia. Both are very safe for pregnant women. If you have any questions about the anaesthetic you will be given for your caesarean section, you should discuss them with your obstetrician and anaesthetist. Before an anaesthetic is given, an intravenous drip will be inserted in your arm to give you fluids and medications during the surgery. A number of monitor leads will be placed on your chest, arm, and finger to monitor your heart rate, blood pressure, and oxygen levels in the blood during the operation. If you have a regional anaesthesia, you will be awake. Only the part or region of your body that is going to be operated on is numb. For a caesarean section, this involves numbing the nerves that are responsible for feeling to the uterus and the abdominal wall. This will numb the lower half of your body, including your abdomen and legs. The types of regional anaesthetic available for a caesarean section are spinal anaesthetic and epidural anaesthetic. The majority of caesarean sections are performed under a spinal anaesthetic, It acts quickly and lasts for only a few hours, just to cover the time of the operation. An epidural anaesthetic is commonly used in labour. If a caesarean section becomes necessary, the epidural anaesthetic can be topped up to make it suitable for the surgery. For most women and babies, it is preferable to be awake for a caesarean section, but a general anaesthetic may be necessary if there are difficulties with regional anaesthetic. You have a serious bleeding tendency. The caesarean section is expected to be very complicated. About 1 in 50 caesarean sections are performed under general anaesthesia. A drip will be placed in your arm and medicine will be given through the drip that will make you sleep. You will not feel or be aware of the surgery. If a general anaesthetic is required, the anaesthetic can sometimes cause your baby to be sleepy for a short time. A paediatrician will be present at the birth in case your baby needs any extra support until the effects of the anaesthetic wear off. Your partner or support person will not be present if a general anaesthetic is required. There are usually 3 members of the surgical team directly involved with the operation: your obstetrician, the surgical assistant, who is usually another obstetrician, and the theatre nurse. Also present in the operating room will be the anaesthetist, the paediatrician and/or the midwife, and/or the neonatal nurse, and the operating room support staff. Once the anaesthetic is working, a catheter, a tube, will be placed into the bladder to help you pass urine after the surgery. A thin strip at the top of the bikini line is shaved before the surgery. Antiseptic is painted on your stomach. A drape, a screen, will be positioned to block your view of the surgery. If you have a regional anaesthetic, the anaesthetist will check that the block is effective and that you are completely comfortable before the surgery begins. Once the regional anaesthetic is in place, your partner or support person is usually able to come into the operating room to be present for the birth of the baby. They will sit beside you, but will not be able to see any of the surgery. You will have some awareness of pushing or pressure feelings during the surgery, but you will not feel anything sharp or painful. If you are at all uncomfortable, you should tell your anaesthetist. Usually a cut is made in the skin horizontally along the bikini line, a few centimetres above the pubic hairline. A horizontal incision is performed most commonly because there is less pain after the procedure and the wound heals very well. Occasionally, a vertical or midline incision is required if the caesarean section is likely to be complicated. After the abdominal cavity is entered, an incision, a cut, is made in the uterus. Usually the incision is horizontal or transverse. Once the uterus has been cut, the amniotic fluid around the baby, starts to drain. You may notice a sucking or slurping noise as the amniotic fluid is being sucked away from the operating field. The baby is usually delivered head first. Forceps are sometimes needed to assist with the delivery of the head. If the baby is presenting breech, the baby will be delivered bottom first. With twins, the baby who has been coming first will usually be delivered first. Once the baby is born, the umbilical cord will be clamped and cut. You will be able to see your baby as soon as he or she is born. The midwife or paediatrician will then place your baby on the resuscitation trolley to dry your baby, ensure your baby is breathing normally, ensure your baby has a good colour and heart rate, trim the cord close to the umbilicus. Give your baby vitamin K if you have given your approval. Your partner or support person may be able to join your baby at this time. Your baby will be wrapped up to keep warm and brought over to you to hold. Depending on the effects of the anaesthetic, you may need some help to hold your baby. You may have some skin-to-skin contact at this time. Shortly after this, your baby will usually be transferred to the postnatal ward, accompanied by your partner or support person. In some cases, your baby may be able to stay with you and accompany you to the recovery room. The placenta is removed and the uterus checked to ensure it is empty. The uterus and abdominal wall layers are closed with dissolving sutures, and then the skin closed with sutures or staples. A clean dressing is applied over the wound, and you will then be transferred to the recovery room. Observations will be taken of your blood loss, blood pressure, pulse, and temperature for a further 30 to 60 minutes. You may experience some cramps during this time or experience some nausea. The staff in the recovery room can give you medications for this if needed. Your legs will be numb for several hours after a regional anaesthetic. You will leave the recovery room to be with your baby in the postnatal ward when your observations are confirmed to be stable and you are comfortable. You will usually be able to start drinking a few hours after the caesarean section. Most women are able to eat later that day or the following morning. If a general anaesthetic is required, eating and drinking may be slightly delayed. The catheter will usually be removed the day after your surgery. Occasionally, the catheter may need to stay in longer. For example, if there has been heavier than usual bleeding during the caesarean section. The intravenous drip will usually be taken out once you are drinking sufficient amounts. Occasionally, the drip may be needed for longer if there has been heavier than usual bleeding during the caesarean section, or if intravenous antibiotics are needed. You will be given painkillers during the post-operative period. These are usually long-acting narcotic, strong painkillers, and anti-inflammatory medications given orally. Occasionally, anti-inflammatory medication may be given rectally. Some patients have an intravenous form of pain relief. It is important that you take sufficient pain relief so that you are able to move around comfortably after the operation. The day after the surgery, you will usually be comfortable enough to shower, toilet, and attend to your baby more or less independently. There will be a midwife assigned to you every shift to assist you when required. Initially, you will probably need some assistance with breastfeeding, but there is no reason why you shouldn't be able to successfully feed your baby. The wound will require a dry dressing for about a week. In most cases, the wound is closed with dissolving sutures, which means they do not have to be removed. Occasionally, staples or non-absorbable sutures are used. These will usually be removed around day 5 to 7, depending on the type of abdominal incision used. The skin will heal over in the first few weeks, but numbness over the scar area may persist for several months. Usually, you will be eating, drinking, moving comfortably and looking after your baby by day 3 after the surgery. Most women return home between day 3 and day 5 after a caesarean section. For the first few weeks at home, you will probably require some pain relief for wound pain. Your obstetrician will prescribe painkillers for you to use at home. Complete healing of the wound takes approximately 6 weeks. You should avoid heavy lifting and strenuous exercise for this time. Vaginal bleeding may continue for up to 6 weeks. As long as your bleeding is getting lighter in flow and darker in colour, this is normal. If your bleeding ever becomes heavy and bright red again, you should contact your doctor. Once the bleeding has settled, you may resume sexual intercourse. Most women will feel confident to drive after 3 to 4 weeks. It is important to check with your doctor and your car insurance company before you resume driving. You should have a post-delivery check of you and your baby, either with your obstetrician or general practitioner, at about 6 weeks. All births involve small risks to the mother and baby. There are some risks that are slightly higher with caesarean birth and some risks that are slightly lower with caesarean birth. It is not possible in this education module to detail all the possible risks of a caesarean birth. We will discuss the major risks associated with caesarean birth. These risks may be higher or lower in your case, depending on the reason for your caesarean birth and other risk factors you may have. It is very important to discuss with your doctor the individual risks to you of your caesarean birth. For most women, there is no increased risk of excessive bleeding or postpartum hemorrhage with a planned caesarean birth compared to a planned vaginal birth. In approximately 4 in 1,000 planned caesarean sections, a blood transfusion is required. The risk of bleeding is higher for births where the placenta is low-lying, placenta previa, or expected to be stuck, placenta accreta. In these situations, blood will routinely be cross-matched and available for your delivery. You should discuss the possible need for blood transfusion with your doctor. Any abdominal surgery can result in damage to surrounding organs such as the bowel, bladder, or blood vessels. The risk of damage to these organs at planned caesarean section is approximately 1 in 100. The risk is higher if the caesarean section is particularly difficult, especially if there is a lot of scarring from previous abdominal surgery. If damage is done to one of these organs at the time of your surgery, this will be repaired. This may require an increase in operating time, making a larger abdominal incision than originally planned, increased blood loss and need for transfusion, a longer recovery period and hospital stay. There is a slight increase in the risk of serious infection with planned caesarean birth compared to planned vaginal birth. This infection most commonly comes from the wound, bladder, or lining of the womb, endometritis. You will be given antibiotics at the time of the operation to lower the risk of infection. It is important to tell your doctor if you notice any of the following after your caesarean section: a fever, redness, swelling, bleeding or leaking of fluid from the wound which might suggest a wound infection, burning, stinging or frequent urination which might suggest a bladder infection, excessive vaginal bleeding which becomes bright and heavy, having previously been lighter and darker, which might suggest an infection of the lining of the uterus. Blood clots in the leg and lung, called deep venous thrombosis, are more common after caesarean section than vaginal birth. For this reason, you will probably be given blood-thinning injections for a few days following surgery. The duration of the treatment will depend on whether you have other risk factors for deep venous thrombosis, such as a family history of clots, your age, your weight, if you are a smoker. You should discuss the need for blood-thinning medication with your doctor. During labour and vaginal delivery, a combination of hormonal signals and some compression of the baby's chest assist the baby to clear fluid from the lungs. This is not the case with a planned caesarean birth, and some babies may experience breathing difficulties, respiratory distress, which is usually temporary. However, the baby may be admitted to the nursery for some help with their breathing. The risk is lower the more mature your baby is at the time of caesarean birth. It is estimated that breathing difficulties, respiratory distress, occurs in 11% of babies born at 37 weeks, 6% of babies born at 38 weeks, 1.5% of babies born at 39 weeks. A planned caesarean birth will usually be scheduled for around 39 weeks. Where delivery is necessary prior to 39 weeks, your doctor may suggest some steroid medications to reduce the chance of breathing difficulties for your baby. You should discuss this with your doctor. A caesarean section for one birth does not mean that future births need to be caesarean sections. Generally, it will be recommended for future births if you have had more than one caesarean birth, the incision has been a classical incision, up and down rather than left to right. Following just one transverse, lower segment caesarean section, you may be able to attempt vaginal birth next time. This is referred to as a trial of labour after caesarean section. Other factors to be considered when weighing up a trial of labour after caesarean versus repeat caesarean birth are the reason your caesarean section was done the first time, the number of babies you are planning for your family, the size of the baby in a subsequent pregnancy, the facilities available to monitor you in a subsequent labour, your personal preference. The majority of women who have a trial of labour after a caesarean section succeed in having a vaginal delivery. It is important to consider the benefits of a vaginal delivery, such as a shorter hospital stay and less pain relief when considering a trial of labour. However, there is a small risk of scar rupture during labour following a previous caesarean section. This occurs in about 7 in 1,000 trials of labour after caesarean section. Scar rupture poses significant risks to both the mother and the baby. For this reason, your labour will need to be carefully monitored. The more caesarean sections you have, the greater the chance that the placenta will attach to the uterus abnormally in subsequent pregnancies. This can lead to serious complications. It is important to discuss the safest option for a subsequent delivery with your doctor and/or midwife. This will depend on many factors, particularly the number of children you are planning to have. This module has been designed to provide you with important information about a caesarean section, what your care will involve during and after the surgery, the implications of both the anaesthetic and the operation, the major risks of this procedure. It is important to discuss with your doctor your individual risks, which may be higher or lower than the average risks due to the reasons for your proposed caesarean section and the presence of other risk factors. Overall, a caesarean section is a very safe way to give birth and be born. Thank you for your attention. If you have any questions after watching this patient education module, please speak to your obstetrician and midwife.